Hi everyone, Abhijit Pinhas here. This is part 2 of my shoulder impingement video. In the last video, we discussed various classifications and the reason why we should classify shoulder impingement and be more specific about it. Just a quick recap, there are two types of shoulder impingements, external impingement and internal impingement. Today we're going to delve a little further into this and talk about some causes that might be leading up to impingement of your shoulder. So here's the model of the right side shoulder. As you can see, when placed on the right side, it's not exactly in the frontal plane, but more in a scapular plane like that, where the scapula is almost in that direction, and we have the clavicle right up here, of course the humerus on the side. Let's discuss some of the structures that we can find here. So basically, we have the rotator cuff, which is the muscle running in between the acromion process and the humerus. As you can see, there's a slight gap over here, not a lot of room for the muscle to pass through. And then we also have some other structures like this one strand of muscle here, which is running more anteriorly to the shoulder and passing through the bicipital groove going down. So that's the bicep tendon. It goes and attaches to the glenoid fossa. Every time you're trying to raise your arm up in an external impingement, the impingement is happening at the subacromial or the bursal side of the rotator cuff, which is basically the top side of the rotator cuff right around here, and that's happening at this between the acromion and the humerus. So again, the top surface over here, compared to internal impingement, which happens due to excessive external rotation of the arm. I can't really move this humerus all the way because it's really held together by all these structures, but that would be the articular surface. So the internal impingement happens at the articular surface, which is the undersurface right here, and the compression is of the undersurface of the articular surface with the posterior, I don't know if you can see this, but the posterior superior part of the glenoid rim. So let's break it down a little further. External impingement could be broken down into two categories, the primary and the secondary. So the primary external impingement generally occurs because of reasons that are somewhat out of our control, which is basically a different shaped acromion process. So what I mean by differently shaped acromion is, imagine if an acromion process was protruding out even further and decreasing the space through which the muscles or the rotator cuff muscles run. To give you an idea of that, here's the spine of the scapula, and as we know, the acromion is the end of the spine of the scapula, which is right here, and that's the space through which the muscle runs. Now imagine an acromion process that was protruding even further out and was hooked even further more, and guess what that would do to the space around here? It would probably decrease it even further and causing more impingement every time. Now, as you can see in the image here, there are three different scapular shapes that are presented. The first one, which is this one right here, basically has a whole lot more room for the rotator cuff to operate during arm elevation, as there's more space between the head of the humerus and the acromion process. In the second kind of scapula, where the acromion protrudes out a little bit, which is depicted by the red line over here, clearly there's less room for the rotator cuff to work. And compare that to a hooked shaped acromion, which is depicted by the green line over here, where the space is even narrower for the rotator cuff to operate and function out of. Now, unfortunately, we cannot use our examination skills or a special test to determine if somebody falls under this category. The only way we could find this out is if we put somebody in an X-ray and we see the acromion to be sticking out or hooked, reducing the space, or if somebody is cut open and a surgeon looks into the scapula. Now, if you have a shoulder impingement patient coming in, what you'd really be hoping for is your patient falling into this secondary category of shoulder impingement. Now, secondary category of shoulder impingement is something that we as physiotherapists could really help our patients with. And some of the reasons why somebody could have impingement due to these secondary factors, some of the factors are a bad posture, really kyphotic, excessively kyphotic posture, tight thoracic spine or stiff thoracic spine, sorry, tightness of certain muscles like the lats, the teres muscle, muscle imbalances like imbalance between or weakness of the rotator cuff muscle and overdominance of the deltoid muscle, which can cause compression. And basically bad positioning or excessively downwardly depressed or abducted or adducted position of the scapula on the rib cage. For the most part, patients coming in with complaints which fall into the category of external impingement, primary or secondary, generally tend to complain of pain more on the anterior part of the shoulder. Whereas the next one that we're going to discuss, which is internal impingement, patients more generally complain of pain more at the posterior part of the shoulder. So let's talk about internal impingement or articular-sided impingement. As we discussed earlier, in this kind of impingement, the main area that is affected is the undersurface of the rotator cuff muscle, which is right around here, compression of the undersurface or the articular surface of the rotator cuff with the posterior superior part of the glenoid rim. This generally happens a lot of times when you have patients who are really active athletes playing sports like, say, cricket, badminton, baseball, pitchers. Think of all the sports in which a person has to really externally rotate and maybe throw a ball or use a racket to hit. And imagine doing this over and over again, the same motion causing impingement of the muscle at the back. Now, there are a number of reasons why somebody could have pain with internal impingement, but a lot of times it's because of excessive and repeated motion and weakness of the muscles and inability of the muscles to stabilize themselves in this position.